So let's start with rhabdomyosarcoma now. It's one of the most common childhood soft tissue sarcomas. It's a relatively rare tumor, but in the child group it may be a bit more common. Most common age group, majority of the children are less than 10 years, and the age by itself has been identified as a independent risk factors apart from the various other. The common sites in which RMS occurs is mostly the embryonal subtype. So before that we can see even the subtypes of RMS: embryonal, alveolar, pleomorphic. Out of which pleomorphic is rare, embryonal is the common subtype, and embryonal has a better prognosis. The alveolar is aggressive and has a very poor prognosis. Alveolar rhabdomyosarcoma. So the common sites, mostly embryonal, occurs in the head and neck. So when it comes to head and neck, it can occur anywhere. The orbit is one of the most common sites, and orbital RMS is considered relatively as a favorable subtype. So again in head and neck, if there is a parameningeal RMS, that is considered as an unfavorable subtype. Then we can have genitourinary, in which usually it is seen in the infants. The most common site could be the bladder wall or even the vagina. And then RMS can occur in the extremities such as hands and the foot. So this is about the basic introduction and the sites and the subtypes. See the clinical features, again it becomes site specific: orbit, proptosis, double vision restriction, parameningeal can present with seizures, headache, raised ACP symptoms. Genitourinary will present with lower abdominal pain, hematuria, could be abdominal swelling, any mass protruding out through the vagina. And RMS is usually a very locally infiltrative disease with a pseudo capsule, and usually noted to have extension into the muscle and the facial plane, and then goes to the lymph nodes. You see the RMS being a locally infiltrative aggressive disease, 50% of RMSs could present with hematogenous mets, 15 to 20% of the cases. Investigation, again local imaging based on the symptoms. Usually since it's a sarcoma, MRI with contrast is the preferred of that particular subsite, be it MRI pelvis with contrast, MRI head and neck with contrast, MRI of the extremity with contrast. And at least the CECT, thorax, abdomen, pelvis is usually completed as part of the metastatic workup. If not, a PET-CT can also be done. For a bladder growth, we obviously need a cystoscopy and a biopsy. An entire proper pelvic examination needs to be completed in a case of rhabdomyosarcoma. So coming to the staging, stage 1 is a localized disease. It is completely resectable. Stage 2 or a group 2 disease is essentially a group 1 is a localized disease, and where regional lymph nodes are not confined to the organ or the muscle. Group 1. Group 2 is compromised surgery or regional resection. Only can be grossly resected with microscopic residual disease, or a regional lymph node which may be involved is group 2. Group 3 is basically biopsy or an incomplete resection with gross residue. Microscopic residue grossly resected is group 2. Gross residue with incomplete resection or a biopsy only is group 3. Group 4 is distal metastasis. And favorable sites are orbit, non-parameningeal head and neck, and non-bladder, non-prostate genitourinary is favorable. The others become unfavorable. Extremity RMS is automatically falls into an unfavorable criteria. Parameningeal is unfavorable, bladder is unfavorable, prostate is also unfavorable site. So there are certain additional points which can do staging. We have T1 confined to site, T2 extend just beyond the site, N0 no nodes, N1 evidence of recent lymph nodes. It could be T1A, T1B, or T2A, T2B based on the size, less than 5 centimeters or more than 5 centimeters. So the entire staging will depend on the site also. So it's easy to remember the stage as a site. See, it is a favorable site. It is T1, T2, N0, then it is stage 1. unfavorable site T1, T2, N0, M0, stage 2. The moment it becomes node positive or it's an unfavorable site, it becomes stage 3. Node positive with unfavorable site becomes stage 3. Any site M1, stage 4. So this is the usual, the basics of rhabdomyosarcoma. And systemic therapy, being an aggressive disease, systemic therapy plays a major part. It's usually multimodal, surgery followed by local therapy. So it could be surgery, local therapy, could be surgery or RT, neoadjuvant chemotherapy or an adjuvant chemotherapy based on the risk stratification. So COG classifies RMS into low risk, intermediate, and high. Low risk is embryonal subtype, favorable site, completely resected. Intermediate, unfavorable site or residual disease with metastatic or alveolar subtype with a FOXO1 mutation. Then it becomes a high risk disease. The chemotherapy backbone in the COG protocols, if you see, it is the VAC regimen: vincristine, actinomycin, cyclophosphamide. So if you see a low risk disease, this VAC regimen, VAC, vincristine 1.5 mg per meter square, actinomycin D 0.045 mg per kg, and cyclophosphamide 1.2 gram per meter square. The usual regimen, it goes on for 22 to 24 weeks. So 6 months of chemotherapy roughly in a low risk subtype. Vincristine, actinomycin D, cyclophosphamide. So chemo the duration is for 22 to 24 weeks. Or other intermediate group, one more chemotherapy is ifosfamide, vincristine, actinomycin D. For a very high risk, if you are going to give intensified protocol, then it could be VAC plus IE, like in Ewing's. So the standard approach is VAC. In the European protocol, they follow the IVA protocol. IVA is ifosfamide, vincristine, actinomycin D. In very metastatic high risk disease, to intensify, we add IE. So usually, if you see, instead of it is usually chemotherapy first approach. The neoadjuvant is the standard. First we start with VAC or whatever regimen, and then if it's local therapy, it's done in between. Say RT is done at the 12th week of treatment after starting VAC in an orbital RMS. So role of RT is usually in the IRS group 2, group 3, unresectable tumors, margin positive, alveolar histology requires RT, and nodal positivity indicates RT. Cross reduced microscopic disease and unresectable disease, node positive, IRS group 2, group 3, RT. RT is usually timed, as I said before, 12th or 13th week of chemotherapy. We can consider early RT if there is poor response to chemo. So if there is no residual disease, group 1 IRS we don't consider it. Group 2 microscopic disease, we go up to 36 to 41.4 gray in conventional fractions. Group 3 gross disease, at least the 50.4 gray needs to be given. So usual range, if this is gross disease, we go 45 to 50.4 gray. Orbital RMS, particularly if you see, we go to 45 gray and maybe boost to 50.4, that gross disease. Parameningeal skull base, we give 50.4 gray, 50.4 in 28 fractions. This is the common. If you have nodal only disease, you give 41.4 gray. So this is the RT protocols. And if you see bladder and prostate RMS, historically, anterior pelvic excentric is combined with chemotherapy. Only that resulted in 70 to 80% 5-year OS. IRS2 itself we evaluate for chemo followed by delayed surgery, which actually resulted in inferior survival. IRS3 further they intensified with the use of planned irradiation at 6 weeks after treatment and added cisplatin plus doxorubicin. And this IRS2 protocol, IRS3 protocol They have tried various methods to intensify the regimen. So if you see the low risk, it is ideally surgery plus or minus VAC plus VAC usually, or VAC followed by surgery. RT only if residual disease is there. Intermediate we give VAC or ifosfamide vincristine aclamacin, and RT is usually mandatory and delayed surgery can be done. In high risk subtypes, it is just intensive chemotherapy, VAC plus IE, and RT to the primary site or metastaticity if it is in selected low volume metastatic disease, maybe yes, or else it's always been systemic therapy. And follow for toxicities, and since it's a younger child, in most regimens it's usually chemo based. Child, RT, second malignancies, increased toxicities, all that complications are there. So we write about response assessment with MRI or PET, and then we write about follow-up and toxicity plans in RMS. Late toxicities might include growth retardation, infertility, secondary malignancies, and endocrine dysfunction.